Good morning, everyone. I'm Dr. Asim Hussein, and I'm excited to welcome you to today's presentation. We'll be exploring acute tubular necrosis, or ATN for short. This is the first slide, so I just want to give you a quick overview of what we'll cover. We'll discuss what ATN is, its causes, clinical features, diagnosis, and management. I hope you find this session informative and engaging. Let's get started. All right, let's examine this case carefully. We have a 68-year-old man in septic shock who develops acute kidney injury. Now, septic shock often leads to hypoperfusion of the kidneys, which can cause different types of AKI. Looking at the urine findings, the urine sodium is 48 mmol per liter, which is relatively high, and the fractional excretion of sodium, Phe-Na, is 3%. This suggests that the kidneys are still trying to excrete sodium appropriately, indicating that the damage is likely pre-renal or early intrinsic injury rather than post-renal. Additionally, the presence of muddy brown casts is a classic feature. These casts are typically associated with acute tubular necrosis, which is an intrinsic form of kidney injury often caused by ischemia or toxins, especially in the context of hypotension or shock. So, considering the clinical context, septic shock leading to hypoperfusion, the urine findings, and the casts, the most likely cause here is acute tubular necrosis. This is a common scenario in septic patients when the kidneys suffer from ischemic injury. In summary, this case underscores how septic shock can precipitate intrinsic kidney damage, with the hallmark features pointing toward acute tubular necrosis. The correct answer here is C. Now, let's break down why this is the best choice. When we see a high Phe-Na, specifically greater than 2%, it indicates that the kidneys are losing sodium more than they should be. This is usually a sign that we're dealing with intrinsic renal damage, such as acute tubular necrosis, or ATN. Additionally, the presence of muddy brown granular casts in the urine is a classic hallmark of ATN. These casts are formed from dead tubular cells and debris, which is characteristic of this type of kidney injury. So, putting it all together, a high Phe-Na over 2% combined with muddy brown granular casts points strongly toward ATN, which is an important diagnosis to recognize in cases of acute kidney injury. Recognizing these signs helps guide our management and treatment strategies effectively. All right, let's take a closer look at this question. We have a patient who has been on gentamicin for 7 days and then develops acute kidney injury, but notably, without any signs of hypotension. Now, the question is, what is the most likely mechanism behind this kidney injury? Looking at the options, we need to consider the different types of acute tubular necrosis, or ATN, which is a common cause of AKI. The first option, ischemic ATN, usually occurs when there's significant hypotension or hypoperfusion, but since this patient has no hypotension, we can probably rule that out. Next, nephrotoxic ATN is caused by direct injury to the renal tubules from toxins or drugs, and gentamicin is well known for its nephrotoxic potential. So, in this case, the kidney injury is most likely due to the direct toxic effect of gentamicin on the tubular cells. The other options, prerenal azotemia, typically result from decreased blood flow to the kidneys, again often associated with hypotension or volume depletion, which isn't present here. Postrenal causes involve obstruction, which doesn't seem to be indicated in this scenario. And acute interstitial nephritis, or AIN, usually presents with allergic features like rash or eosinophilia, and often occurs after longer exposure or with other signs. So, tying it all together, the key takeaway is that gentamicin can cause direct tubular toxicity leading to nephrotoxic ATN, even without systemic hypotension. This highlights the importance of monitoring renal function during aminoglycoside therapy. Correct answer is B. Now, let's understand why. Aminoglycosides, which are a class of antibiotics, are known to cause nephrotoxicity. Specifically, they can lead to acute tubular necrosis, or ATN, which is a type of kidney injury. This injury primarily affects the proximal tubules, the part of the nephron responsible for reabsorbing nutrients and electrolytes. So, when we see a patient on aminoglycosides presenting with kidney issues, we should think about this potential toxic effect. Recognizing this helps us make better clinical decisions and monitor for early signs of nephrotoxicity. This connection between the drug and its adverse effect is essential in understanding drug safety and patient care. All right, let's take a closer look at this question. We're asked to identify the phase of acute tubular necrosis, or ATN, that best explains a clinical scenario where, on day 5, there's a rising urine output, but the serum creatinine is still increasing. Now, this is a classic pattern we see in the progression of ATN. In the early phases, the injury causes a decline in kidney function, leading to decreased urine output and rising creatinine levels. But as the injury starts to resolve, the kidneys begin to recover, and urine output increases even though the serum creatinine may still be elevated. This scenario is characteristic of the recovery phase of ATN, where the kidneys are beginning to heal. The important concept here is that urine output can improve before serum creatinine levels normalize, reflecting the ongoing recovery process. So, connecting this to the overall theme, recognizing these phases helps us understand the natural course of AKI and guides our management strategies. Therefore, the best answer here is the recovery phase, where we see this pattern of rising urine output despite still elevated creatinine levels. The correct answer here is A now. Let's talk about the diuretic or recovery phase. During this stage, you'll notice that urine output actually improves before you see a drop in creatinine levels. This is an important point because it indicates that the kidneys are starting to recover, and urine production increases even while the creatinine levels are still elevated. Recognizing this pattern helps us understand that improvements in urine output are an early sign of renal recovery. So, in the broader context of managing kidney injury, paying attention to urine output can give us valuable clues about the patient's progress, even before lab values like creatinine stabilize. All right, let's focus on this challenging scenario. We have a patient with oliguric acute tubular necrosis, which means their kidneys are not producing enough urine. The lab results show a potassium level of 6.2 millimoles per liter, which is quite high, and they also have pulmonary edema. The key here is to recognize that hyperkalemia at this level can be dangerous, potentially leading to cardiac arrhythmias. Meanwhile, pulmonary edema indicates fluid overload, which complicates the management because we need to carefully balance fluid removal without worsening kidney function or causing hypotension. So, when considering the options, we want to choose the most effective and safest step to stabilize the patient. Starting with IV fluids might seem counterintuitive given pulmonary edema, but in some cases, cautious fluid management is necessary. Loop diuretics could be helpful to convert oliguric to non-oliguric kidney injury, but they might not be sufficient or safe here given the high potassium and pulmonary edema. Dopamine isn't typically recommended anymore for renal support, and dialysis is often the definitive treatment when medical management isn't enough, especially with severe hyperkalemia and fluid overload. Finally, sodium bicarbonate can help temporarily shift potassium into cells, but it alone is usually not enough in severe hyperkalemia. Given all this, the most appropriate next step is likely dialysis, as it effectively removes potassium and excess fluid rapidly and safely. That's why, in this scenario, dialysis stands out as the best choice to stabilize the patient promptly. The correct answer here is D now. Let's talk about why. When we see AEIOU indications, it often points us toward the need for dialysis. Specifically, these signs can suggest serious issues like hyperkalemia, which is an elevated potassium level that can be life-threatening, or pulmonary edema, where fluid builds up in the lungs and impairs breathing. Recognizing these indications is crucial because they guide us toward prompt and effective intervention, such as dialysis, to remove excess toxins or fluids. This ties back into our overall theme of timely diagnosis and management in critical cases. So, always keep an eye out for AEIOU signs. They're key clues pointing to the need for dialysis in urgent scenarios. Alright, let's take a look at this question. We're asked to identify which finding favors acute tubular necrosis, or ATN, over prerenal acute kidney injury. Now, this is an important distinction because both conditions can present similarly, but their management differs. Starting with option A, phenol less than 1% is typically seen in prerenal AKI because the kidneys are conserving sodium to maintain volume. So, a low phenol actually suggests a prerenal cause, not ATN. Option B, concentrated urine, is also characteristic of prerenal states, where the kidneys are trying to conserve water and sodium, leading to high urine osmolality. Option C, a rapid response to fluids, again points towards prerenal AKI. If the kidney function improves quickly after volume repletion, it's usually prerenal. Now, option D, muddy brown casts, are classic for ATN. These casts are formed from necrotic tubular epithelial cells sloughing off into the urine, which is a hallmark of intrinsic renal damage like ATN. Finally, option E, high urine osmolality, again tends to be seen in prerenal states, where the kidney is concentrating urine effectively. So, connecting all this, the key point here is that the presence of muddy brown casts strongly favors ATN over prerenal AKI. This helps us differentiate the intrinsic kidney damage from a volume-depleted, prerenal state. Recognizing these findings is crucial for appropriate management and treatment decisions. The correct answer here is D now. Let's look at why that's the case. Granular casts are actually quite characteristic of acute tubular necrosis, or ATN. These casts are composed of finely granular material and are formed within the renal tubules. When you see granular casts on a urinalysis, it's a strong indicator that ATN might be involved. This is important because identifying granular casts helps us distinguish ATN from other renal conditions. Remember, the presence of these casts points towards tubular injury, which is central to ATN. So, recognizing this feature in your diagnostic process is key to diagnosing and managing patients accurately. Let's take a closer look at acute tubular necrosis, or ATN for short. This is a type of intrinsic renal acute kidney injury, meaning it originates within the kidney itself. It typically results from either ischemic injury, which happens when the blood flow to the kidneys is reduced, or nephrotoxic injury, caused by harmful substances damaging the renal tubular epithelial cells. When these cells are injured, several key problems occur. First, there's a loss of tubular cell polarity, which disrupts the normal function and organization of the cells. Second, tubular obstruction can develop because of casts. These are conglomerates of cells and proteins that block the flow within the tubules. Additionally, we see a backleak of filtrate, meaning that the filtered fluid that should be processed and excreted ends up leaking back into the bloodstream. All of these issues contribute to a reduced glomerular filtration rate, or GFR, which is a crucial measure of kidney function. It's important to note that ATN is actually the most common cause of acute kidney injury in the intensive care unit setting. Recognizing these features early can help us intervene promptly and potentially improve patient outcomes. Let's start by understanding the key differences between ischemic and nephrotoxic acute tubular necrosis, or ATN. In ischemic ATN, the damage is patchy, characterized by areas of necrosis due to inadequate blood flow. On the other hand, nephrotoxic ATN involves direct injury to the proximal tubules, often caused by toxins or drugs. Focusing on nephrotoxic ATN, the primary culprits are certain drugs and endogenous toxins. For example, aminoglycosides, which are antibiotics, can cause significant tubular injury when used at high doses or over prolonged periods. Amphotericin B, used for fungal infections, is also notorious for its nephrotoxic potential. Cisplatin, a chemotherapeutic agent, can damage the kidneys, and radiocontrast agents used in imaging studies are another common cause. Vancomycin, especially at high levels, can also lead to toxicity. Moving to endogenous toxins, substances like myoglobin released during rhabdomyolysis, hemoglobin from hemolysis, and uric acid in tumor lysis syndrome can all contribute to tubular injury. Now, shifting to ischemic ATN, the main causes are related to decreased blood flow and oxygen delivery to the kidneys. Septic shock is actually the most common cause in ICU settings because widespread infection leads to systemic hypotension and poor perfusion. Prolonged hypotension itself, cardiogenic shock, major surgeries or trauma, and massive hemorrhage can all severely compromise renal blood flow. So, in summary, nephrotoxic ATN is primarily caused by certain drugs and toxins directly damaging the tubules, while ischemic ATN results from insufficient blood flow due to shock states or severe hypotension. Recognizing these differences helps us understand the underlying mechanisms and guides appropriate management. Let's take a closer look at the pathophysiology behind acute tubular necrosis, or ATN. When tubular epithelial cells get injured, they can undergo necrosis or apoptosis, which essentially means they die off or programmed cell death. This cell injury causes the cells to slough off into the tubule lumen, forming muddy brown granular casts that you might see in urinalysis. These casts are a hallmark of tubular damage. Now, these sloughed cells and debris can lead to tubular obstruction, which impairs the flow of filtrate. At the same time, there's backleak of filtrate, further disrupting normal kidney function. As a result, despite adequate renal blood flow, the glomerular filtration rate, or GFR, decreases. This is a key point because it highlights that the problem isn't just blood supply, but how the tubules themselves are damaged. One of the most important consequences of this damage is that the tubules lose their ability to concentrate urine. Normally, tubules help conserve water and produce concentrated urine, but when they're injured, this function is impaired. This loss of concentrating ability contributes to the clinical picture of ATN, with issues like diluted urine and potential volume disturbances. Overall, understanding this sequence, from cell injury to impaired filtration and concentration, helps us grasp why ATN can cause significant kidney dysfunction, but also why some of these processes are reversible if we intervene early. Now let's look at an important point about creatinine levels. Even as the urine output starts to improve, creatinine may still continue to rise. This can sometimes be confusing, but it's a key concept to understand in managing acute kidney injury. Moving on to the clinical phases, we see a progression through different stages. The initiation phase begins with an insult that causes a sudden drop in the glomerular filtration rate, or GFR. This is when the kidney first starts to be affected. Next is the maintenance or oliguric phase, where we typically observe rising creatinine levels, along with hyperkalemia and acidosis. This phase can last for a variable period, and it's critical to monitor these parameters closely. Finally, during the recovery or polyuric phase, the kidneys start to recover, leading to diuresis, an increased urine output. However, this phase comes with its own risks, such as hypovolemia and hypokalemia, so careful fluid and electrolyte management is essential. This slide specifically highlights acute tubular necrosis, or ATN, which is a common cause of intrinsic renal failure. Recognizing these phases and features helps us understand the progression of kidney injury and guides our management strategies. Let's start by noting that Phe-Na can be unreliable when patients are on diuretics, so in those situations, we prefer to use Phe-urea as a more accurate marker. Moving on to the key parameters for diagnosing acute tubular necrosis, or ATN. First, urine sodium levels tend to be greater than 40 mmol per liter, reflecting the kidney's inability to reabsorb sodium effectively. Similarly, the Phe-Na percentage is usually above 2%, indicating impaired tubular function. Urine osmolality in ATN is typically less than 350 milliosmoles per kilogram, showing the kidney's reduced concentrating ability. When examining the urine sediment, we often see muddy brown granular casts, which are characteristic of ATN and point to tubular cell injury. Putting all these pieces together, the diagnosis of ATN relies heavily on urine and lab findings, and recognizing these patterns helps us distinguish it from other causes of acute kidney injury. This slide encapsulates the key diagnostic features that are essential for our understanding of ATN within the broader context of kidney injury assessment. Now, let's look at some key features that differentiate prerenal AKI from acute tubular necrosis, or ATN. First, the Phe-Na, or fractional excretion of sodium. In prerenal conditions, Phe-Na is typically less than 1%, indicating the kidneys are conserving sodium due to decreased perfusion. In contrast, with ATN, Phe-Na exceeds 2% because the tubular damage impairs sodium reabsorption. Next, let's consider the casts seen in the urine. Hyaline casts are common in prerenal AKI, often reflecting concentrated urine but not necessarily damage. However, in ATN, granular casts are more prevalent, signaling damaged renal tubules shedding cellular debris. When it comes to response to fluids, prerenal AKI generally shows improvement with volume repletion, as restoring perfusion helps restore kidney function. Conversely, in ATN, fluids alone usually don't lead to significant improvement because the tubular injury has already occurred. Understanding these differences is crucial for accurate diagnosis and management. Recognizing the features of ATN helps us differentiate it from prerenal causes and guide appropriate treatment strategies. Let's start with a quick overview. Diuretics, while often used to manage fluid overload, do not actually improve overall outcomes in kidney failure. They're mainly for symptom relief. Now, moving on to indications for renal replacement therapy, or RRT, which we often refer to as AEIOU. These are the key reasons to consider starting RRT. First, acidosis, specifically when the blood pH drops below 7.1, indicates a severe acid-base imbalance that needs correction. Next, electrolyte disturbances, particularly refractory hyperkalemia, are critical, as elevated potassium levels can cause dangerous cardiac arrhythmias. Then, intoxications, certain poisonings or drug overdoses, may require dialysis to remove toxins. Overload, especially pulmonary edema, is another indication. If fluid accumulation affects breathing and isn't manageable with diuretics, RRT can help. Lastly, uremia, which manifests as encephalopathy or pericarditis, signals that waste products are building up to dangerous levels, necessitating intervention. Moving into management, especially in the ICU setting, the focus is on core principles. First, treating the underlying cause, whether it's sepsis or hypotension, is essential to improve renal function. We also want to avoid nephrotoxins that may worsen kidney injury. Optimizing blood pressure, specifically maintaining a mean arterial pressure of at least 65 mmHg, helps preserve kidney perfusion. Careful fluid balance is equally important, neither overloading nor dehydrating the patient. And finally, in cases like acute tubular necrosis, or ATN, these principles guide us to prevent further damage and support recovery. Remember, the main goal is to manage the condition thoughtfully, balancing interventions to support renal function while addressing the root cause. Now, let's talk about the prognosis of acute tubular necrosis, or ATN. Generally, the good news is that ATN is usually reversible, meaning with proper management, many patients can recover kidney function. However, there are certain factors that can make the outlook worse. For example, if ATN is associated with sepsis, the prognosis tends to be more guarded. Sepsis can cause widespread inflammation and damage, complicating recovery. Similarly, if the patient experiences multi-organ failure, the chances of full recovery decrease because multiple systems are affected, making the overall condition more severe. Age is another important factor. Advanced age often correlates with a poorer prognosis, likely due to decreased regenerative capacity and comorbidities. So, while the outlook can be positive, these factors, sepsis, multi-organ failure, and older age, are key to understanding the overall prognosis in ATN cases. Recognizing these helps us tailor our management and set realistic expectations for recovery. Let's talk about the MRCP pearls regarding ATN, or acute tubular necrosis. It's actually the most common cause of ICU-acquired acute kidney injury. When you see muddy brown casts in the urine, that's a classic sign pointing toward ATN. Another important diagnostic clue is a Phe Na greater than 2%, although we need to be cautious if the patient is on diuretics, as they can alter this value. Keep in mind that rising creatinine levels often lag behind the actual injury to the kidneys, so a gradual increase might not reflect the full extent of damage immediately. And just because diuretics can increase urine output doesn't mean the kidneys are actually recovering. It's important not to be misled by that. Overall, recognizing these signs helps us differentiate ATN from other causes of AKI and guides our management strategies effectively. Thank you all for being here today. I truly appreciate your time and attention throughout this presentation. We've covered a lot of ground, from the key concepts to the practical applications, and I hope you found it both insightful and inspiring. Remember, the main takeaway is how these ideas can make a real difference in your work and projects. Your engagement and curiosity are what drive progress, so keep exploring and applying these concepts. Once again, thank you for your participation and interest. I look forward to seeing how you implement what you've learned.